Welcome to COVID Talks. I have the pleasure to have with me Dr. Chaand Nagpaul. Dr. Nagpaul is a family physician from London, and he is the chairperson of the British Medical Association. He is also a member of the World Medical Association Council. Welcome, Dr. Nagpaul.
Hello. Hi, Otmar.
Dr. Nagpaul, Great Britain has been hit quite hard by COVID-19, and like your neighboring countries, this has brought the healthcare system to the limits. Now, what have been the measures in the UK to increase the surge capacity of the healthcare system?
So the UK, obviously, following Italy and Spain, knew that this pandemic had the potential to overwhelm our healthcare system. Remember that the UK didn't have a starting point of a strong infrastructure. We had about a quarter of the ITU beds of Germany, for example. So the government early on planned for this and made efforts around procurement of ventilators in particular, and also asked for manufacturers who had never manufactured a ventilator before to look at domestic production, as well as, of course, international imports. But in addition to that, we needed more capacity in hospitals for critical care. And again, the UK starting point is lower than EU averages. The government did this in a variety of ways. One, it block purchased capacity from the private sector. The private sector in the UK is separate from our National Health Service, but it bought capacity until the end of June to make use of those beds and some intensive care facilities. It also took a decision to reduce all non-essential work or elective work, and hospitals have been repurposed so that large parts of the facilities are now COVID work. And it's also built new hospitals, and we have now about three, what we call Nightingale hospitals, that have been specially adapted new units to cater for patients. The biggest one being in London, and it's a massive exhibition centre that has now been converted into a hospital. It was built or adapted in a very short space of time in relative terms, less than 2 weeks.
Have there been measures also or ideas to, for instance, recover workforce from retired personnel or to fast-track students?
Again, sadly, the UK is below the EU average in terms of the numbers of doctors we have per 1,000 patients. And so what the government did early on was to announce that it would add to that workforce in two ways. One, bringing back to service retired doctors. And these retired doctors were written to by our General Medical Council, and they were put back on the registration unless they opted out. No charges for registration, and they've also been offered induction in the sort of work they can do. We were very concerned to make sure that retired doctors who, by definition, are in the older age group and at more risk of serious ill health if they contract COVID-19, we were very concerned that they should not be put at risk. So their work, to some degree, can be remote, or provide advice to a national telephone medical helpline, which has been overwhelmed with demand. So this is a really useful service. And much of, as we know, medical work doesn't have to be in terms of working in an infectious environment. So the retired workforce certainly has been one plank. The other is medical students. And the government have offered medical students in their final year an accelerated qualification without waiting to do their examinations in the summer, using an assessment of their work throughout the course to be qualified and add to our workforce. So those measures have certainly occurred. There's a third thing that I'm sure most nations have done, which is to repurpose our existing medical workforce to be doing new work to support the COVID pandemic. So ENT doctors, dermatologists, and those services which in fact have now been put on hold, except for urgent situations, the workforce has been redeployed to provide care in acute settings.
Now, with ramping up these services and these capacities, you probably also have seen a sharp rise in the demand for PPE. Other countries around have seen a lack of supplies. Is that something the UK has experienced as well?
Oh, this has been probably the biggest issue facing the profession, that supplies have been short. I raised this right at the beginning on behalf of the British Medical Association. We have what we call a Health Select Committee, a government watchdog that held a special meeting on this, and I gave evidence because we were told by the UK government that there were sufficient stockpiles based upon pandemic planning. But when it came to it, we were finding week on week that there were reported shortages. And the British Medical Association has doctors, and we have regional branches and contacts with hospitals across the UK and general practices. And we were finding that many supplies hadn't reached hospitals and GP practices. For example, eye protection in particular had not been supplied to significant numbers of family doctors, and there's been shortages of certain types of masks, and now in particular full sleeve disposable gowns. We've had that information. Remember, one thing about the UK is it is a state run service. The supplies and the organisation of provision of PPE is a state responsibility. So we have a good picture of what is or isn't being supplied. Certainly what I found in my own GP family practice is we've had to rely on the generosity of local schools and some charity organisations to give us eye protection. Remember, it's not easy to buy supplies at this moment in time because all the major online suppliers have run out of stock, and I think some of them have sort of secured deals with maybe government or other international requirements. So this has been a real difficulty. The difficulty has been added to by, as we all know, the risk to healthcare workers becoming ill. And we were very acutely aware of when Italy, in particular, suffered the losses of so many doctors and healthcare workers. And that added to our concerns that doctors working in an environment without proper protection are putting their own health at risk, the risk to their families. But let's not forget that by becoming infected, a doctor will be at risk to other patients because of the lag between symptoms appearing and still being infectious, but also the risk of asymptomatic spread of the virus.
That leads me to another question. The World Medical Association has several times asked for the situation of pandemics and disasters, that there is a special shield for health professionals, for doctors, for nurses, against, on one side, legal claims, liabilities that may come up, but also for the health damages they may experience during that time, including death, of course, which has happened in many cases, unfortunately. So is there a protection? Is there a compensation for those who get ill by COVID-19 or even may die? Is it seen as an occupational disease?
Yes, I mean, we again have been very, very clear from the outset that doctors, by their nature of their job, are putting themselves at risk. And if any healthcare worker was to die during the pandemic, that the government has a moral duty to look after the dependents of the deceased doctor. Just yesterday, after a lot of lobbying from the British Medical Association, the government has announced a package of compensation. It's basically not, in our view, sufficient or fair to everyone. It's a fixed sum of 60,000 UK pounds, which is applied to all healthcare and care staff who die. So it's actually a fixed sum for everyone. I should add that most doctors in the UK who are on an NHS pension scheme do have what we call death in service benefit. So there is protection for death through our pension scheme, but there are many doctors who are not in the pension scheme and those who are coming back from retirement. And for them, the £60,000, we believe, will not stretch as far as it should to care for dependents.
You have yourself several times expressed concerns about minority populations. Why do you think that they need special attention?
No one would have expected that when we heard about healthcare worker deaths, that the first 10 doctors who died were all from a Black and Asian ethnic minority background. I mean, that's goes beyond any statistical variation that can be explained. So that was a very stark figure. And when that happened, I called on the government to conduct an investigation, but more than the investigation, to put in place mitigations to protect our healthcare workers and those who appear to be particularly affected by this virus. Now, remember that, in fact, out of those healthcare workers, the vast majority have come from overseas. So our health service has a debt of gratitude to our overseas medical workforce. And tragically, since that called from me to investigate, we've now seen more than double those numbers of doctors who have died. And in fact, 94% of doctors who have died, now well over 20, have all come from a Black and ethnic minority background. So these are statistics that defy anything that would be attributed to logical explanation. And we need to understand why this is happening and protect our Black and ethnic minority doctors. What the government have done is it's announced a review, but what we are calling for is for a risk assessment process to occur in every single hospital or family doctor provider, which can stratify risk and protect those healthcare workers, those doctors, from BME backgrounds who have additional risk factors that place them at greatest risk. And that tool, I hope, will be developed very shortly. We really needed it by now, because, as I said, each week that goes by, we're hearing about more deaths.
So let me just for a moment come back to the population. Did the testing start early enough, and did the public health service enough tests in the beginning in order to find out the situation of COVID-19 in the UK?
It started early enough in that when COVID-19 first emerged in the UK, there was testing and measures taken to make sure that anyone with a cough or symptoms of a fever were tested. But that was quickly overtaken by a policy of not testing generally and assuming that there was spread in the community, and an approach of self-isolation if you were ill with no testing at all. And the only testing that had continued was for those who were admitted to hospital. And this has been a source of frustration for us, because we believe that the testing should have been continued at a much greater level in order to understand the level of spread and to take action to trace and isolate. So I think that the answer is that it started okay, but we believe it did not continue and expand to meet the demand. And the government took a view to empirically self-isolate those who had symptoms. And this, of course, doesn't capture those that are asymptomatic. It also doesn't follow the sort of science of public health measures to identify those who've been in contact with an infected person. So that hasn't been happening in the UK, and we believe that should have been, drawing upon the examples, of course, some of the nations who took such a rigorous approach and prevented the spread of the infection.
Now, when we look to the statistics, we have very divergent numbers, and sometimes we have very high death rates per million, and in other nations, lower ones. This may have to do with the spread of the COVID-19, but it probably also has to do with the way that deaths are counted. We just recently have learned that the NHS now is going to include also death from outside hospitals into the statistics. Would you like to say something about that?
Yes, I think, it's so important that we have information that is comparable between different nations. Otherwise, we won't understand how we can learn from this pandemic, and we won't be able to compare how different nations have intervened in different ways. And the problem we've got is that in the UK, for example, the deaths that have been recorded until just this week have only been hospital deaths. And we know that significant numbers of deaths were occurring in the community, but not featuring in the figures. So when we saw those graphs, for example, across Europe, the UK figures were compared to others, but we weren't comparing like with like. And what has now been occurring is that deaths in the community have been added to the figures that are from hospital. But even that doesn't capture the full extent of infection or deaths, because we're only going by deaths which have occurred from a positive COVID test result. And we know that not all nations are testing all their population to the same extent. So the figures become even less easy to compare, because it might be that our figures are underestimate, because many other deaths, like from pneumonia, we wouldn't be sure whether the patient died of COVID-19 related illness or not. And so that sort of information is not currently being recorded if it's not had a positive test result. And I suspect, similarly, we have the same situation in other nations. So I think if there's something to learn, there is something about consistent data collection internationally if we are to learn and from that learning, prepare for a future pandemic.
Now, in the time when we are thinking about exiting from the restrictions that the different nations have taken and the different restrictions people have been subjected to, there are a few things that are very clear, like distancing is important, hygiene is extremely important. But then there are other things like, for instance, covering your face, using face masks, surgical face masks, or just a face cover is something that is highly controversial and is handled very differently from place to place, not only between nations, but also within nations sometimes. So what is the BMA position on face masks or face covers?
In fact, the BMA, like I think most of us, are finding that there is real inconsistency in the judgment of science, especially where the science doesn't exist. And each nation will say they're guided by science. So in the UK, the four governments, England, Scotland, Wales, Northern Ireland, have until recently all said the evidence was weak and have not promoted it. Scotland, only 2 days ago, is the first nation in the UK to advocate the use of face coverings in public. What I find really difficult is that we have other nations like Germany that have been very clear about the use of face coverings in public places like supermarkets. And we've seen now with Spain easing the lockdown, actually offering masks to the public for free as they enter railway stations, for example. Austria using masks. We have the WHO saying there's no real evidence for the public wearing it, whereas the CDC in the USA say that actually you should wear it when you go out. And I think at a time like this, it's not just a case of it being confusing, but my view is that if there is any small but real chance of reducing spread, we should take that, because the stakes in this illness, this virus, are so high that if any deaths, however small, can be reduced, we should take that step, especially if that step is not going to be of any harm to the medical profession. And that's the critical point, because we need to be clear what this face covering is. Whilst there are PP shortages, what we must not do, of course, is divert the sort of masks that are in short supply for doctors and nurses to the public. But at the same time, it can be as simple as a face covering, or you can manufacture a non-surgical face covering. But in other nations, they have provided the public with surgical face masks. So I think that we need to rapidly try and, as a profession across the world, come up with a view, because we don't want to be making this decision in weeks to come if each week we could be reducing community spread. I think for some of this, sometimes we rely heavily on science when there's a little bit of common sense involved, because in terms of hygiene, we've said for a long while that if you cough or sneeze, you should cover your face or mouth with your hand or with your elbow. So it just seems logical that if the public are mixing with each other in a supermarket, for example, to have no face covering at all just would increase the risk of transmission. So I don't think this is about something too technical. And I must say, my gut feeling is I understand the reasons why many nations have taken this approach, but it would be helpful to have an international view, ideally from the WMA.
Thank you very much for giving me that interview and for taking the time.
Thank you.